Good morning and welcome to the October 2020 IPMG informational webinar. My name is Lana Hunt, Director of Communications and Professional Development for IPMG. Today, in observance of Breast Cancer Awareness Month, which is marked in countries across the world every October, IPMG's RN consultant, Laura Dieter, will provide information that will increase attention and support for breast cancer awareness, early detection and treatment, as well as special consideration for individuals with intellectual and developmental disabilities and for those that are aging. 1 in 8 women will be diagnosed with breast cancer in her lifetime. IPMG believes that it is important to be proactive about your health and the health of the individuals that you support. By increasing awareness, it is hoped that both women and men become more attentive to the signs and symptoms of breast cancer and increase the chances of detecting breast cancer in its early stages. Today's webinar will be recorded and available on IPMG's website within 2 business days. At the end of the presentation, a short survey will be shared, and we encourage everyone to complete the survey so that IPMG can continue to provide relevant and helpful informational webinars. All attendees of today's webinar will receive an attendance certificate at the email used when registering, again within 2 business days. It is now my pleasure to introduce Nurse Laura Dieter. Laura has been a nurse for 15 years and has been IPMG's RN consultant for 2.5 years. She has experience in medical, surgical, cardiac critical care, ER and hospital administration, and health and wellness nursing. In addition to her professional activities, Laura is a wife and mother to 2 boys, ages 4 and 3, and has taught Pilates for the last 7 years. It is now my pleasure to, good morning.
Good morning.
Laura, you can take it away. Yes.
Awesome. Thank you, Lana, for the introduction. As Lana said, we're going to be talking about breast cancer with considerations for individuals with intellectual and developmental disabilities and our elderly population. So jumping right in, breast cancer is a type of cancer that starts in the breast. Cancer occurs in the body when cells begin to grow out of control. Most breast cancers will form a tumor that can be felt as a lump or seen on an X-ray, such as a mammogram. Breast cancer mostly affects women. However, men can get breast cancer as well, although this is rare. 1 in every 883 men will be diagnosed. Breast cancer is the 2nd most common cancer in American women, falling only behind skin cancer, and the 2nd leading cause of death in women. Lung cancer is number 1. The average risk for a woman in the United States to develop breast cancer, as Lana stated, is 1 in 8 or 13%. The American Cancer Society estimates over 276,000 new cases of invasive breast cancer and over 48,000 new cases of non-invasive breast cancer will be diagnosed in 2020. Around 2,600 cases of breast cancer will be diagnosed in men. And around 42,000 individuals will die from breast cancer this year alone. The good news is that from 2013 to 2017, the death rate decreased by 1.3%, and there are currently over 3.5 million breast cancer survivors in the United States alone. So looking at those considerations for women with disabilities, women with disabilities typically have the same risk, but worse outcomes as other women. They typically have more factors that put them at higher risk, and they also more often face challenges and barriers that other women may not have to experience. They have higher breast cancer mortality rates and lower rates of regular screening. Given that 1 in 4 women have a disability, we need to increase our education and efforts to make sure that we include this population of women. Age also places women at a disadvantage in terms of risk. The older the woman is, the more likely she will be diagnosed with breast cancer. On average, there is about a 9% chance that a 60-year-old woman develops breast cancer over the next 20 years. Half of all newly diagnosed breast cancer cases come from women over the age of 60. And women over the age of 65 who are diagnosed with early onset breast cancer are more likely to pass away from the disease and more likely to have a relapse. So one study that was completed on this population showed that 8.3% of women who were 75 and older died during the study's follow-up period, compared to those 65 and younger at 5.7%. The risk of relapse was also shown to be greater for women aged 65 to 74, where they compared at 7% compared to 29% for those 75 years and older. So there's a big big discrepancy there. One of the reasons for this disparity is that research shows that doctors tend to treat breast cancer in older women less aggressively than when diagnosed in younger women. And we'll get more into that topic later on when we talk about treatment. So talking really quickly just about the different types of breast cancer. Breast cancer can start from different parts of the breast and can also refer to whether the cancer has spread or not. In situ breast cancer, also known as ductal carcinoma in situ, is a non-invasive cancer that starts in the milk duct and has not spread to the surrounding breast tissue. The term invasive is used to describe cancer that has spread into the surrounding tissues or the lymph nodes. The most common forms of invasive breast cancer are invasive ductal carcinoma and invasive lobular carcinoma. Invasive ductal carcinoma makes up about 70 to 80% of all breast cancers. Less common types of breast cancer include triple negative breast cancer, which accounts for about 15% of all breast cancers, inflammatory breast cancer, which makes up about 1 to 5%, and phylloid tumor and angiosarcoma, which are both more rare. And what we're looking at here is the overall survival rate, so that's why those percentages don't match up. All right, there are certain lifestyle and hereditary factors that can increase your risk for breast cancer. We're going to take a closer look at those. However, I do want to note that a lot of women who are diagnosed with breast cancer have no risk factors or very little risk factors. And alternatively, women with very high risk may never develop breast cancer. So risk factors play a role, but it's not the end all be all. So lifestyle factors are those that we can control. This includes drinking alcohol, being overweight or obese, not being physically active, not having children or later in life pregnancies, not breastfeeding, using birth control, hormone therapy after menopause, or breast implants. Those all increase our risk for breast cancer. And then switching over to hereditary factors, these are factors that we don't have control over. So the first one is being female. Obviously, we don't have a choice on what we are born as, and we know that being female increases our risk. Getting older, most breast cancers are diagnosed over the age of 50, as we've stated. Genetic mutations, so the BRCA1 and BRCA2 genes. For me, I was more aware of it after Angelina Jolie told her story. If you're not familiar, she was tested, her mother passed away from cancer. She was tested positive for the BRCA1 gene. And in her story, she talks about how she had an 87% chance of getting breast cancer. So she underwent a preventative double mastectomy. If you are diagnosed with a BRCA1 gene, you have a 50 to 70% chance of having breast cancer. BRCA2 is a 40 to 60% chance by the age of 70. Now, this genetic testing is a little controversial because once you know whether you test positive, then you have to make the decision of what you're going to do with that. So, but it is available for those that are at a higher risk. Reproductive history, anybody who has menstruation before the age of 12 or late menopause after the age of 55. The increase in risk, they believe to be due to a longer lifetime exposure to the hormones estrogen and progesterone. Personal history of breast cancer. Women who've had breast cancer in the past have an increased risk of getting it a second time, which just seems unfair. Family history. The risk is higher with a first-degree relative, such as a mother who had breast cancer, or multiple family members on either side of the family. Although it is important to note that 85% of breast cancers occur in women with no family history. So just because you don't have family history of breast cancer does not mean you are out of the woods. Previous treatment using radiation therapy. Women who've had exposure to radiation therapy to the chest before the age of 30 or just have a general higher exposure to radiation have a higher risk. Race, oops, I'm getting behind here. Race and ethnicity. White women slightly more likely to develop breast cancer than African American women, although that gap is starting to close. In women under the age of 45, breast cancer is more common in African American women, and African American women are more likely to die from breast cancer at any age. They are also more likely to have triple negative breast cancer. I thought this one was interesting. Being taller increases your risk. The reason isn't exactly clear, but some believe it has to do with factors that affect early growth, such as hormonal or genetic factors. And lastly, dense breast tissue. Women with dense breasts on a mammogram have a risk of breast cancer that is 1.5 to 2 times of that of women with average breast density. Unfortunately, dense breast tissue can also make it harder to see cancers on mammograms, so most likely you will undergo further testing. And really quickly, I just wanted to talk about a couple disproven or controversial risk factors. I'm sure you've seen one or all of these talked about. First, deodorants, antiperspirants. A lot of people have come to believe that aluminum and other ingredients in deodorants are absorbed through the skin and interfere with lymph circulation, causing toxins to build up in the breast, eventually leading to breast cancer. According to the American Cancer Society, there is little to no evidence to believe that antiperspirants increase the risk of breast cancer. There are lots of aluminum-free deodorants to choose from, so that is obviously a very personal choice whether you want to use aluminum or not. Bras, sorry ladies, there was no evidence to show that bras increased your risk for breast cancer. It was believed that the underwire bra decreased lymph flow, again, leading to breast cancer, and that was disproven. And finally, induced or spontaneous abortions. Studies have shown very conclusive evidence that neither of those have any link to increased risk of breast cancer. Our most significant risk factors for breast cancer are 2 things that we don't control: being female and advancing age. Knowing your risk factors, your signs and symptoms, and obtaining regular screenings are key to early detection and better outcomes. So again, looking at those considerations for our special populations, women with disabilities tend to have more risk factors. Early menstruation, previous chest radiation, or just overall radiation. Never having children, obesity, and overweight. 38% of adults living with disability are obese. Being physically inactive, and obviously being female. Age, as we know, are at a much higher, women of advanced age are at a much higher risk for developing breast cancer. Hormone therapy after menopause also increases the risk of getting and dying from the disease. So make sure you or your individuals that you're serving are talking with their physicians about alternatives to hormone therapy so that you can make and they can make informed choices. It's really important to know the risks and benefits of medications that you're being prescribed. So one of the most important factors in beating breast cancer is catching it at the earliest possible stage. We can do that by knowing the signs and symptoms of breast cancer, performing monthly breast exams, and getting regular screenings. The most common symptom of breast cancer is a lump. Finding a lump, especially after the age of 40, is cause for concern. However, most lumps found on the breast end up being benign. Only around 20% end up being cancerous. Lumps on the breast can be a sign of breast cancer, but they aren't the only sign and symptom that indicates potential breast cancer. So we're going to take a closer look at these. Discharge from the nipple. So any discharge from the nipple, whether it's clear, discolored, runny, or thick, can be an indication of breast cancer. It can also be an indication of other issues, but should be checked out by a physician. And that goes for all of these signs and symptoms. Swelling and or soreness. Breast cancer can cause a general swelling or soreness of the breast that does not go away. The swelling would be significant enough to change the size and the shape of the breast, and it can affect the whole breast or just part of it. Nipple inversion. The composition of the nipple can change if there's breast cancer present. The cancer cells affect the area right behind the nipple, causing it to invert or turn inwards. Redness of the skin usually indicates that there's something going on, especially in the area where there are cancer cells present that are affecting the lymph nodes. Any redness or warmth of the skin typically indicates that something isn't quite right. Skin dimpling. This is where parts of the skin on the breast invert and create a dimple. This can show where the cancer is present, and it also can be an indicator of aggressive cancer. General changes to the skin or the size and shape of the breast, peeling, flakiness, and crustiness in the area surrounding the areola or other parts of the breast. And lastly, swelling underneath the arm. Swelling or tenderness under the arm can suggest breast cancer is present. Cancer cells typically travel to the lymph nodes underneath the arm after affecting the breast tissue, causing swelling or pain. Should you or anyone of your individuals that you serve notice any signs or symptoms of breast cancer, it's imperative that you are seen by a physician as soon as possible. The physician will perform a breast exam and most likely order one or more of the following tests: a mammogram, ultrasound, MRI, or even a biopsy. And we'll talk about that here in just a second. But first, we're going to hear from Judy.
This story is presented by the Centers for Disease Control and Prevention, CDC, Safer, Healthier People.
My name is Judy Rogers, and I would describe myself as a disability health activist. I have cerebral palsy that affects one side of my body. I had breast cancer and started noticing all the issues that come up when we look at the impact on somebody with a disability. I knew I was at risk because my mother has breast cancer, my maternal aunt had breast cancer, and my mother's first cousin had breast cancer. I did a manual breast exam, and I did find my lump. I was having screenings for 10 years prior to them finding the cancer. I am very happy to be alive. If you catch breast cancer earlier, your fear will be much less than pretending it won't happen. You have more treatment options, more options altogether. The problem with disability is the limited options. So getting your screening early increases those options. Accessibility is really improving across the country. Keep looking for that accessible site. It's your life, and no one can protect it better than you. We don't have a way to prevent breast cancer. All we have is early detection. It's really clear the earlier you get it, the best recovery. If you don't see or feel a lump, that doesn't mean it's not there. You have to do all that's available to you: mammography, the manual self-exam, and the doctor's exam. Please be forthcoming. You know your body, and you need to express what your body needs. You have to be passionate. Your body's the only one you have. Breast cancer does not mean a gravestone. It means a bump in the road that you've experienced before, and you can move on. And the best thing you can do for your fear is early detection and trust your body.
And now that's going to lead us talking into diagnosing breast cancer. A mammogram is simply an x-ray of the breast, and at this time is the best way to find breast cancer early when it is easier to treat and before it is big enough to feel or cause symptoms. The U.S. Preventative Service Task Force recommends that women who are 50 to 74 years old and are at average risk for breast cancer get a mammogram every 2 years. Women who are 40 to 49 should talk to their providers about when to start and how often to get a mammogram. Women should weigh the benefits and risks of screening tests when deciding whether to begin getting mammograms before the age of 50. Speaking from personal experience, my physician stated mammograms should start yearly at the age of 40, no matter your risk. However, I did some digging and I could not find any change in that recommendation from the American Cancer Society or from the Preventative Service Task Force. So that could just be a physician preference, but I have heard that from many physicians that mammograms are now starting at the age of 40. Ultrasounds and MRIs are also used to get a deeper image of the breast. If you've been diagnosed with dense breast tissue, an ultrasound or MRI may be recommended after a mammogram to get a closer look at the breast tissue. A biopsy will be ordered if the doctor is suspicious of cancer. The physician would insert a needle into the area of concern and extract cells for further testing. If the cells come back as cancerous, the biopsy would be able to determine if the cancer was invasive or not. Further testing would be needed, though, to determine if the cancer had spread to other parts of the body. And we're going to take a listen to June's story and her history with breast cancer.
This story is presented by the Centers for Disease Control and Prevention, CDC, safer, healthier people. I'm June Kales. I very much identify as a woman with a disability. I was born with cerebral palsy. I was diagnosed as having breast cancer in June of '02. My maternal grandmother had breast cancer, so I thought I was at risk. The screening process for me for breast cancer has been an ordeal. It's been one which started with a doctor saying, you must have a psychological problem. You can't seem to stay still when you're having a mammogram. So I tried to explain to him that it was about my disability and not about a psychiatric problem. So I finally found a provider who would listen to me. Once I found him, I stayed with him for many years. I take charge. And I say to the technician, listen, don't tell me not to move because I can't stay still on demand. And we'll work at this together. And what I find are the good technicians say, thank you for telling me that. It's very helpful to know what works for you. And the bad ones, they just ignore me. When you first get a mammogram, you don't know what to expect. So it took a few years for me to figure out what might work for me. I think that things are easier now than they were before. More and more machines are more flexible in terms of positioning. There are quite a few women who live with physical disabilities who don't get screened, and the reason is that they have to go through so much crap. It takes a lot of emotional energy to go to begin with. Don't let the system beat you down. Get what you need. You know your body better than anyone else. Insist on an accessible mammography. They exist out there. It's going to be harder maybe for some women than for others, but it's worth the battle to get what you need. We need to be vigilant about understanding our disability and how it may affect any kind of condition and communicate that to providers. Breast screening, well, I equate it with control over my health and wanting to maintain health in any way I can. If you value your life and your health and you'd like to be around for a long time, it may not be easy. It may take more energy, but it's worth it.
Right. I love June's story. She really does highlight some of the disadvantages women with disability face in obtaining regular mammography. According to the CDC, in a study conducted in 2010, women with disabilities age 50 to 74 living in the U.S. were less likely to have received a mammogram in the last 2 years, 61% versus 75%. In Indiana, we fared a little bit better at 73% versus 79%. Women with IDD who lived with their families were least likely out of all women with IDD to receive regular mammography. The study that was done with these families noted that the families caring for those with disabilities were more concerned with medical care that improved the quality of life, not necessarily prolonged life. Other issues that the families addressed were just lack of education around screening, physicians not ordering the test, and not seeing their loved ones as, quote, adults. Lack of access is one of the biggest barriers to breast cancer screening for women with disabilities. Transportation to the testing site may also be an issue, and many local centers may not be designed for women who have difficulty getting around. Another obstacle is that mammography equipment may not adjust enough for some people to easily get into the right position or to sit should that be required. Tips for those with disabilities or those who care for women with disabilities or the elderly, this applies to them as well. You want to call ahead to make sure that the center can meet the individual's needs. You don't want to wait until you get there to find out that it's not going to work for them. When the mammogram is scheduled, let the staff know about the disability or the issues that they face ahead of time, whether the individual needs to remain seated, if they can't sit still, as in June's story, if they are nonverbal. Let them know ahead of time so they can prepare as much as they can as well. Have staff and family go with the individual to make the individual feel more comfortable. Educate the individual on what to expect ahead of time to prepare them for the test. There is a lot of touching of the breast that occurs. There's a lot of maneuvering around, shifting into position. So let them know what to expect, so it's not a surprise once they get there. Let the scheduling staff, radiology techs, or radiologists know if the individual can or cannot sit upright without assistance, lift or move their arms, transfer from the chair to the scooter, or dress or undress without assistance. And lastly, if you are not happy with the service, speak up on how things can improve. Everyone there wants to make the experience the best that they can. So speaking up in a respectful way will go a long way to help bring about some change. And if you are not comfortable speaking out in the moment, call them later after, write an email. I'm really good with strongly worded emails. Or just contact them however you feel most comfortable, but speak up so that it can change for others. Once breast cancer has been diagnosed, there are many ways it can be treated, depending on the kind of cancer and how far it has spread. We won't go into great detail about treatment here, but just a general overview of the types of treatment that are common once a diagnosis has occurred. Surgery is an operation that can be performed to remove localized breast cancer, called a lumpectomy, or the entire breast may be removed, called a mastectomy. A chemotherapy, this is given to help shrink or kill the cancer cells and can be given in pill form or through an IV. Radiation therapy, this uses high energy rays to kill the cancer cells. And lastly, hormonal therapy, this blocks cancer cells from getting the hormones that they need to keep growing and reproducing. All right, so there are no clear ways to prevent breast cancer, but you can reduce your risk by maintaining a healthy lifestyle. Maintaining a healthy weight, studies show that an increase in body weight and weight gain as an adult are linked with an increased risk of breast cancer after menopause. Not smoking, we all know that smoking is bad for us. Limiting alcohol intake to 1 glass or less per day. Being physically active, the American Cancer Society recommends that adults get at least 150 to 300 minutes of moderate intensity or 75 to 150 minutes of vigorous intensity activity each week, or a combination of those, preferably spread throughout the week, meaning don't go out and run for 150 minutes on Sunday and then sit around the rest of the week. Breastfeeding has also been shown to have protective benefits for women. So again, looking at those considerations for women with disabilities, the findings in the studies will probably not come as a surprise, but I did think it was interesting. So there was a study done in 2008 that looked at breast conserving surgery combined with axillary lymph node dissection and radiotherapy, or mastectomy in women with disabilities, and how that compared to women without. So in layman's terms, basically the study was looking at whether women with disabilities received the same standard of care versus women without. The study found that women with disabilities had higher breast cancer mortality rates and were less likely to undergo standard therapy after breast conserving surgery than other women. Across all women with early stage breast cancer, women with IDD had lower rates of breast conserving surgery, 43% compared to 49%. Axillary lymph node dissection rates were also lower at 89% versus 97%. So this is recommended to identify lymphatic spread that might require additional treatment or chemotherapy. Those women who had breast conserving surgery also received radiation therapy less often. Standards require that women receiving breast cancer surgery undergo radiation therapy to reduce the risk for local reoccurrence. One of the explanations of the disparity in treatment is that women with disabilities may be more susceptible to treatment-related complications such as infections or toxicities, which may also contribute to the higher breast cancer mortality rates. But the general conclusion was that there is a pretty big gap in the standard of care between women with disabilities and those without. Unfortunately, there were similar findings in the elderly population. So, as noted earlier, breast cancer is commonly diagnosed in older women. It's estimated that 21% of newly diagnosed breast cancer cases are patients over the age of 70. One of the issues with treatment is that older women are underrepresented in clinical trials and evidence on the best treatments are insufficient. Aging is also associated with an increased number of comorbidities, polypharmacy, and geriatric syndromes, along with the progressive loss of resilience to stressors, a phenomenon known as frailty, which is just a fancy way of saying that as we get older, we don't cope with the physical stress that illness puts on our body as well. The large variety and characteristics within this population, the lack of evidence on the most suitable therapeutic approach, and the limited data on older patients' preferences, whether they want to be treated or not, make treatment decision making for these patients pretty difficult. Frail or pre-frail adults have higher risk of experiencing adverse effects and complications from surgery, radiation therapy, and systemic therapies such as chemo or hormonal therapies. It should come as no surprise then that research has shown that doctors tend to treat breast cancer in older women less aggressively than similar breast cancer diagnosed in younger women. Less aggressive treatment might explain, at least in part, why older women have worse outcomes. For example, only 5% of the 48% of women age 75 or older that had breast cancer spread to their axillary lymph nodes received chemotherapy, which again is standard treatment. It could be because of personal treatment preferences. So these women may just be deciding for themselves not to seek chemotherapy, or it can be physician bias. Doctors may also assume that aggressive treatment is not wanted, so therefore they don't recommend it, or that it doesn't make sense because of the woman's age. So once again, it's important that we know all of our options, regardless of your age or disability, so that we can make those best choices. And these are just some general considerations with the disabled and aging population. Women with intellectual disabilities experience even greater barriers, both physical and attitudinal, that prevent them from getting screening and preventative care that they need. 1 in 3 adults age 18 to 44 with disabilities do not have a regular healthcare provider, which increases the difficulty of obtaining regular medical screenings. 1 in 4 aged 45 to 64 did not have a routine checkup in the last year. The ARC of the United States has identified some key barriers to care for people with disabilities. And while this is a general overview, you can see how this will pertain to someone who may be diagnosed with breast cancer. So lack of accessible information about healthy habits or not enough help in navigating the healthcare systems and insurance plans. The cost of attending regular medical checkups and following up with a healthcare provider on any risk identified during a checkup. In fact, 1 in 3 have unmet healthcare needs because of cost in the past year alone. So you can imagine a cancer diagnosis where you're seeing physicians and labs and radiology and surgery and how that cost might add up. Lack of healthcare plan benefits and other insurance-related obstacles to high-quality care and choosing the right provider. Lack of communication training for healthcare providers, making interactions with people with disabilities difficult. Too much emphasis on somebody's disability, leading healthcare providers to skip routine screenings for common diseases or preventable health issues, and just the general discrimination and stigma associated with disability. The elderly have their own challenges that can make obtaining care difficult. One study, which I thought the findings of this were very interesting, reported the most common barrier for an older woman seeking care was that the doctor's lack of responsiveness to patient concerns. So they didn't feel like the physician was listening to them. Other concerns were medical bills, cost again, transportation, and street safety. Low income, lack of supplemental insurance, advanced age, and being female were also listed as barriers to obtaining medical services. So how you as a case manager can help? First and foremost, we obviously need to be an advocate for our individuals and those that we serve. We can start to ask and track medical screenings, including routine medical exams and past mammograms. Educate on the importance of regular medical screenings. If they are past due or have never had a mammogram, help provide them with resources to help them schedule, such as who they would call to get an order for the mammogram, where they might go, and maybe even finding a center that is appropriate and accessible to them. Ask about self-breast exams if they are able to complete. And if they are, consider providing education to those that are at a higher risk and able to perform their own monthly breast exams. Ask individuals and support staff if they've noticed any signs or symptoms. If your individuals are unable to perform their own ADLs, support staff and family will be key in detecting any changes, but they often don't speak up unless specifically asked. Be knowledgeable about the individual's risk for breast cancer. You don't have to have a medical degree to know if somebody is at a higher risk. Just run through that little risk factor that we presented earlier and see how many boxes they tick off. Ask about family history. Do their mother or aunt or grandmother, do they have a history of breast cancer in their family? Support the individual and family and staff in making appointments with their providers and obtaining treatment if needed. Be aware of healthcare documents, living wills, healthcare proxies, power of attorney for health, and/or advance directives. It's important that we know what our individuals want. And finally, take charge of your own health. Perform your own monthly exams, schedule your own mammograms, and live a healthy lifestyle to the best of your ability. You cannot support others if you are not well yourself. And I do challenge you all to think about how else you can serve your individuals in this area. And that is all I have for you guys today. Thank you so much for joining me, and I'm going to let Lana finish it up.
Thank you so much, Laura. This information was very helpful, not only for ourselves, but for the individuals that we support in our roles as case managers and care managers and other support professionals. So again, we will be providing the recording and the associated materials on our website within the next 2 business days. That is at www.gotoipmg.com in the resources section. Also, as a reminder, you will be receiving a follow-up email that will include an attendance certificate that will go to the email that you registered for the webinar. And again, that will be within 2 business days. We will also be having a survey that will be available for you to participate in. And we would really encourage you and would enjoy you sharing with us any personal stories or information that you would like to share related to either your own breast cancer story or for individuals that you have supported, and any other ways that you feel that has been the information that you have received has been helpful. So feel free to add that into the survey, and we would enjoy reading about that. Again, thank you very much, Laura. We appreciate you sharing this information with us, and we do thank everyone for participating in the webinar today. Our next webinar will be held on Friday, November the 20th, and the topic will be on employment and employment benefits for individuals receiving Medicaid waiver services. So please watch for the registration for that to come in the very near future. So thank you again, everyone, and I hope you have a wonderful rest of your day. Bye-bye.